me to really speak to that. I was asked to really speak on the routine measurement of vascular aging and whether that would be implemented into clinical practice. And understandably, this is one of the major questions in this field, which has been great in the past decades in terms of development of the whole concept of vascular aging. And so I think this is a very relevant question, which I not necessarily have the clearest answer, but let's talk through it. So to kick it off, I thought maybe best to break down this title a little bit and speak firstly about vascular aging, which I'm sure this audience would be very well informed about. I will also speak a bit on the routine measurement of vascular age, and then, of course, they'll impact in terms of how to change clinical practice. So if we kick off with vascular aging, and I will just briefly go through this as I don't want to bore you, and I'm sure you have had excellent speakers on this topic already in the previous webinars, but nevertheless, just a quick refresh in terms of early vascular aging was defined before as reflecting the understanding of the pronounced effect of aging on the arteries, vascular tree, and especially on arterial function. And of course, when you look at the structural wall of an artery and the whole process of arteriosclerosis, is this changing amongst other things, but it changes in the elastic membranes and laminae that's throughout the vascular wall, and changes in terms of the elastin collagen ratio and other processes that accompany this. And that is a process that we know occur with normal aging, but then not necessarily at a similar rate in all individuals. So when looking at the complete arterial system, this whole process of arterial changes and increased stiffness is not necessarily that largely obvious in the muscular and smaller vessels. It's mainly reflecting the large arteries, the conduit vessels, the elastic vessels that undergo changes during this process of vascular aging. And that's why most of the techniques in terms of the assessment of arterial stiffness focus mainly on the aorta. So in this beautiful image from Chirinos' paper is, if you look at the compliant aorta, which is healthy, you would see a typical aortic pressure, which is quite low, 102/76, and with a slow pulse wave velocity throughout the aorta. And based on this timing of the arterial wave, you have a beautiful, favorable reflection of the pulse wave, for the backward and forward waves are in a favorable timing, not to cause further harm and damage to the, for example, in this case, to the heart, and having a lower pulsatility because of this elastic and compliant aorta. But in the case of the stiffening, you clearly have a significant change when these arteries stiffen. Change in format, you typically also see, as you can see here, atherosclerotic plaque development, and that results in a stiff artery with a fast pulse wave velocity, or let's say in this case about 12 meters per second. It results in changes in this forward-backward wave timing, the size of the wave as well, and therefore in the end causing damage to the heart muscle, resulting also in reduced coronary perfusion, which is a major impact. And due to this continued excess pulsatility, causes damage to the microvasculature throughout the body, and that's why you typically see microvessels and organ damage in terms of the kidneys, the brain, etc. So that is the typical process that's, I think, reflected in what is called early vascular aging, is when this develops earlier than, or at all, but earlier than in other cases in terms of the chronological age. So a few years ago, I had the fortune to be part of the Lancet Commission on Hypertension. And I think also when you work in this field of arterial stiffness, that's what happened to many of us who actually work on that topic, is when we were confronted as part of the Lancet Commission with a question that we needed to answer is, how can we, if we, it's almost, if you had all choices, in the world, and you were able to change this massive global burden of cardiovascular disease, what would you do to change that? What would be major things that will change this situation? And we had among ourselves lots of interesting conversations, but in the end, as you can also see in the title, it was all about this life course strategy that we decided to make the central theme of the paper to address the global burden of raised blood pressure on current and future generations. So what is also meant with this life course strategies, of course, having situations and favorable environments for people across the life course, from childhood to elderly ages, where you would have a healthy cardiovascular system and function. In other words, if you have population-based strategies to really ensure that people undergo an ideal life course, it would be, for example, environments where you can easily walk around, exercise without any harms, sufficient parks and environments, healthy foods available at low cost, affordable prices, and a low availability of, for example, high salty foods. Just as an example, and there are many others that we need to think of more broadly in how to enhance our environments to become more healthy. But of course, the average life course requires or actually results in a person having at advanced ages already having elevated blood pressure, organ damage, and cardiovascular disease. And at this stage, you need individual strategies. They have to go to a healthcare provider to implement some treatment to try and change this course. But then you have this situation, of course, of early vascular age. Already at middle age, you see a rapid increase in organ damage, cardiovascular disease at younger ages than one would anticipate. And of course, as indicated in this graph, we really want to push this down to the ideal life course, and how to do that is the question. So this is just the general concept. In practice, in clinical practice, it's a different world, one can almost say. And just to briefly also mention this, on top of that, the whole exposure of a mother during pregnancy and the effect that may have on the child's health, this early life program is, of course, also very prominently featured in this diagram. That's why we added an additional graph just to emphasize that aspect. So in terms of early vascular aging, as neatly also highlighted by esteemed colleagues who I think may have all spoken at this webinar series, it's really that we need to take into account that there are some factors that really shape aging and longevity. Genetic programming, the influences with the environment and genes, early life programming, as I've just mentioned. We have also family patterns, sibling rank, shared microbiota, all different things that really come to the fore now as being quite important. And then, of course, the traditional lifestyle factors that we typically hear about, and societal factors and social support. So if you look at these aspects, one could also ask, it's almost identical for what we know in terms of blood pressure. So I always think that when you refer to early vascular aging, you can't really disentangle it very easily from blood pressure. And that's, I think, one of the major challenges in bringing vascular aging front and center to the attention of guideline developers and general practice for that matter. We'll get to that a bit later. So why is it important? It is, of course, important because it's been shown already many years ago. Some of the first ones I've just picked up here was a meta-analysis and systematic review, which referred to the prediction of cardiovascular events and all-cause mortality with arterial stiffness, and where they clearly expressed that aortic pulse wave velocity to be a strong predictor of future events and all-cause mortality. And it also indicated that it is higher in subjects with a higher baseline cardiovascular risk. Reflects all in absolute cardiovascular risk assessment, and already then suggests a potential role for pulse wave velocity to play in risk assessment for future events. In this paper, published even longer ago, in 2006, it was also shown when they looked at the prognostic value in a general population, not necessarily those with high risk, Firstly, I highlighted that it's a really easy measure to take at the bedside to reflect central arterial stiffness, and then concluded aortic pulse wave velocity acquired in a few seconds predicted cardiovascular outcomes, and this is the important part, over and beyond 24-hour ambulatory blood pressure and traditional cardiovascular risk factors. So I think that is the essence here. So it brings significant value on top of the gold standard blood pressure measurement of 24 hours and traditional risk factors. And this was highlighted by the authors already in 2006, that it may be an important actor in risk stratification and also in measurements into clinical practice. That was almost 20 years, 15 years ago. And now we need to ask ourselves, nothing has really changed dramatically there, and why that is the case. So another component of my original question was regarding the routine measurement of vascular age. So how do we do this routinely? Unfortunately, as you may be aware, last year there was this beautiful series in arteriosclerosis, thrombosis, and vascular biology on arterial stiffness. And Patrick Segers and colleagues also then highlighted how to measure arterial stiffness in humans. And this was the graphical abstract of that paper, where they really said which way to go. There is clearly a big question mark on what's the best method. And then they introduced, based on either aortic measurements or local measurements, what they thought was best based on a 5-star grading, looking at direct and indirect measures as well. So there are quite a bit to get someone confused who isn't actively working in the field of arterial stiffness, which I think is unfortunate in bringing the attention to arterial stiffness measurements. Of course, mostly carotid femoral pulse wave velocity is the main measurement that everyone's aware of, and also regarded in the European guidelines as the gold standard measurement. But then the authors also mentioned in the abstract, and I just want to read this verbatim, is that despite the wide recognition of larger artery stiffness as a highly clinically relevant and independent prognostic biomarker, it has yet to be incorporated into routine clinical practice and to make a more prominent position in clinical guidelines. So that's the two factors we want to focus on. An important reason may be the plethora of methods and devices claiming to measure arterial stiffness. And this brief review then really looks at all these different methods and their strengths and weaknesses. So they also acknowledge that that may be part of the challenge, is which method to really use. And as I said, they highlighted very neatly all sorts of different measures and in detail went through them. Mainly gave a 5-star rating to methods with MRI, for example, which is of course something to consider when we think of wide scalability, affordability, and aspects that may guide implementation, wide implementation. Of course, you would all be aware of the fact that almost now 10 years ago, this great expert consensus document was published that really guided people clearly on how to do carotid femoral pulse wave velocity in daily practice. And this document, I think, was really very important to simplify and to make this a generally and widely applicable method to use. And it typically included aspects that one should do, should be performed in a quiet room with stable temperature, etc., how many measurements to take, the position of the patient, etc. And I think this was critically important and very clear at that time in this whole process. Of course, that again, I see that not necessarily as a competition, but when you think of blood pressure, this is a measurement that's been used for more than a century, and you see in every hypertension guideline also this very clear demonstration of how exactly, for example, office blood pressure measurement should be made. So this is well known. So it's good to actually replicate some of this in terms of the process of carotid femoral pulse wave velocity as a measure. So as I said, it's more than 100 years that we've been having the sphygmomanometer, and today the method is not that different, mostly using oscillatometric methodology. But that is to the benefit of blood pressure, because this measure has been there for so many years. It's widely implemented in every continent and in every country. You will find blood pressure monitors. Whether they are accurate or not is now not the question, but there's a lot of emphasis on getting devices out there. Here are some of them, and to make sure that there's a general understanding of the importance of accurate, validated blood pressure device that's used in clinical practice. And that is quite a long way from where we are in terms of arterial stiffness or vascular aging assessment. Whichever method then should be this single one, because ideally that would be the case if we can at least say this is the essential measurement that should be taken. If you have, for example, a clinic or hospital with great facilities, you can also add A, B, and C to it. But I think to simplify and clarify that message, that would be good to advise on a single type of measurement, such as I think what was done with carotid femoral pulse velocity. And yes, so every year or two, there comes new clinical practice guidelines. This year, the European Society, again, as if there's not enough, emphasize exactly how blood pressure should be taken. So it remains an evolving field, and I'm sure that's the same in terms of arterial stiffness or vascular aging assessments. Even the World Health Organization, so you've got really important global buy-in to make sure that there is clear guidelines, for example, this technical specifications document, which was published also last year on what blood pressure devices should be used across the globe. There are also websites such as these with lists of monitors that are accurate and validated and advised or recommended to be used. So this surely for if you want to have vascular aging measurements, it should be a clear guidance as well. Which devices should be used, and are they affordable, are they accurate, etc. So if we focus on the European guidelines, I think the European guidelines was really important in terms of getting vascular aging more to the front and center, at least for people to become more aware of the importance, is the fact that it was listed as a measure of asymptomatic hypertension-mediated organ damage. And they listed arterial stiffening and only two measurements. Pulse pressure, which is pretty easy to get, and we all know the pros and cons there, greater or equal to 60 millimeters of mercury, which can easily be derived from blood pressure measurements, and then the carotid femoral pulse velocity greater than 10 seconds. So that's the only ones that were listed compared to all of these other ones that are available. And what was also then featured there in the guidelines, and I have to mention this because this is really what we need in guidelines to get it into routine care. So it was clearly recognized that it's an important determinant of pressure. It's also indicated that it is the gold standard, carotid femoral pulse velocity for large artery stiffness assessment. And great, there are reference standards available, as you would all know. So that is, I think, also very positive. And then the cutoff is clear, it's simple. And I think that's also a very good criterion. The question comes in at the additive value. So that, I think, is the crux here, is what is the additive value of pulse wave velocity over and beyond or above and beyond traditional risk factors? So there's been studies that show that the European score, absolute cardiovascular risk assessment tool on the Framingham risk score. So there's been studies that show if you add pulse wave velocity to the traditional risk scoring, it does add value. But that's clearly not strong enough evidence, because very clearly expressed that routine use is not practical and is not recommended for routine practice, pulse wave velocity. So that is where we sit at the moment. So if we then focus on clinical practice in itself, how do we get there? In that sense, I think it's also important to have a quick look at how the European guidelines also listed these different sorts of measurements, cardiovascular measurements, measures of hypertension-mediated organ damage, and how they actually rank in terms of, or rate in terms of sensitivity to changes, reproducibility, time to changes, and prognostic value of the change. So it's really, pulse wave velocity was rated high in terms of sensitivity to changes, but reproducibility and operator independence is is pretty low, which is, I think, not good at all. So that's something to look at. And then, of course, time to changes. It's fast. It can change quickly, but there's not sufficient data. That was in 2017, 18, on the prognostic value of the change. So if you were able to reduce pulse wave velocity, would it result in less stroke, less myocardial infarction, etc.? There's not data for that. So what's important for the guidelines, of course, and I just thought I would mention this briefly, is if you look at how they rank quality of the evidence, they have different recommendations. So you always see in these guidelines a class 1, class 2, class 3 type recommendation, and each of these have definitions. So for example, just looking at class 1, it says evidence and or general agreement that a given treatment, or in this case, a procedure, is beneficial, useful, and effective. And therefore, the wording used in the guidelines, it is recommended or it is indicated. Whereas for others, it could be considered, may be considered, or in this case, it is not recommended. So that means the evidence, if it's a class 3 recommendation, evidence or general agreement that the given treatment or procedure is not useful, effective, and in some cases, it may even be harmful. Right, so that is the spectrum. And on the other side, we also have the levels of evidence. And there we have 3 levels, where level A is data derived from multiple randomized clinical trials or meta-analyses, and then going down to consensus or opinion, which is, of course, not a form of evidence. So if we look, for example, at ambulatory blood pressure, automated or out-of-office blood pressures, it's ranked a class 1 level A evidence. It's specifically recommended for a number of clinical indications, etc., etc. There's lots of evidence that it is effective to use out-of-office blood pressure. So that is where we would like to be in terms of measures of vascular aging. So to get vascular aging assessment into practice, we would need critical evidence. Firstly, I think simplicity is always a good thing. It's not always possible, but where possible, I think it's good to go for that. And that is the best single or measurements to use. It should be very clear, right? And I think there should be some sort of a consensus as well by the scientific leaders in this field. Secondly, and I think that's what was done in the 2012 consensus statement for coronary pulse wave velocity assessments. I'm not sure if things have changed. Also, what is important, its measurement should be cost effective for wide implementation. So if it is something for general practice that you want to really implement throughout all countries and you think it would add value and benefit, it is important to be as cost effective as possible. Of course, high-income countries would not be that big a deal in terms of implementing when it's more expensive, but nevertheless, where money is to be saved, that's always a consideration. Or alternatively, if it's not for very wide implementation, then you need to specify which population group needs to be identified. For example, those at borderline risk, and there has been such suggestions by several papers. It may add value in risk stratification for those at borderline or at high risk for future cardiovascular events. Should there, of course, be evidence to show that it is indeed beneficial to have that as an additional risk assessment tool. Its measurement, it actually links better with the first bullet point. The measurement should be standardized to be easily and routinely measured. I think ideally that is something that should be aimed for. And I think it's possible with the technology we have today. Currently, a vascular aging or stiffness is mainly used as a biomarker or predictor of future outcomes. That's to my understanding. And to be a reliable biomarker, it must add clear additional risk discrimination beyond your standard risk factors. And we already saw that in the 2006 paper, and maybe there were earlier ones as well from the group of Stassen. So they already showed it does bring additive value, and there's been several others demonstrating the same. So why is it not taken up? Why is it not being seriously considered? There are several champions around the world for this, but for some reason it's not being taken up, and I think the evidence is not yet convincing enough in terms of large trials. We could also, as a further point here, indicate that vascular aging could potentially also be used to demonstrate the progression and susceptibility of organ damage, because it does change over time. I think it's a great benefit, actually, if you were able, for example, to have pulse velocity assessments over time and see whether treatment is effective in reducing the stiffness, then you know that there is very likely to be a reduction in overall cardiovascular risk as well. But it's also quite interesting, and I think it's something that could and should probably receive much more attention when the value of adding something like arterial stiffness to clinical practice be discussed, is the major issue with blood pressure, which is, as I say, I almost see that as a sort of a competitor against arterial stiffness, because all trials and all research for arterial stiffness needs to demonstrate it is independent of blood pressure, that it suggests or predicts risk, or you can see it's independent of blood pressure. So the trouble with blood pressure is, of course, it is, especially if we focus on office blood pressure, is the inherent intra-individual variability, changing from beat to beat, from night and day, from minute to minute. So and that's something that's not appreciated at all, actually. I think there should be more emphasis on the huge variability of blood pressure. And if you look at the clinic assessment of 3 blood pressures, in half an hour, it could be a completely different blood pressure, actually. So that is not the case for arterial stiffness, unless there's an issue with the operator. And therefore, I think the stability of arterial stiffness assessments and the fact that it could actually extract that cardiovascular risk based on the vessel wall elasticity is something that should be more on the forefront in demonstrating the value of stiffness assessments. And of course, what we also need is multiple randomized clinical trials on how the reducing vascular aging or arterial stiffness result in reductions in major cardiovascular events, such as coronary artery disease, stroke, cardiovascular mortality, beyond blood pressure reduction. And that is, I think, where the central area of focus is. And the challenge is we have masses of data for blood pressure, and beautiful paper published recently also showing that 5 millimeters reduction of systolic blood pressure results in a 10% reduction in cardiovascular risk, based on over 350,000 individual patient data points. So we are far from that with arterial stiffness, and that is the challenge, I think, because those studies were mostly funded by industry to prove in the decades ago that specific drugs are effective in reducing blood pressure. And now there's not typical funding or industry interest in terms of that amount of funding to run these trials with thousands of patients. And I think that is where potentially the bottleneck is in this process. Also, if somebody have then a high pulse wave velocity and reflecting higher cardiovascular risk, what do we do about that? Is there specific treatment that will reduce and improve arterial stiffness? That would then also translate into benefit in terms of cardiovascular outcomes. So that, I think, is also a very important area. And I know there's a lot of work going on, small trials all over, and maybe there are bigger ones that I'm not aware of. I haven't actually worked that much in this field recently, more involved with guideline development and related aspects. And therefore, it would be interesting for me also to hear about ongoing trials, especially the sizable ones that can really draw attention, which are multi-center, multi-country, ideally. And that is to get to this level of evidence. We need multiple RCTs and meta-analysis to really drive high levels of evidence for guidelines. And I mean, everybody working in the field are well aware of the SPRINT trial. So the SPRINT trial was not funded by industry, but it was just a huge randomized trial in over 9,000 participants. And they focused again on blood pressure, reducing blood pressure to much lower than the traditional 140. And they showed that if you have a target of less than 120, with intensive blood pressure treatment, you have a significant reduction in major cardiovascular events, the primary outcome being, in this case, composite of myocardial infarction, acute coronary syndrome, stroke, heart failure, or death. So clearly showing and demonstrating with a huge trial, multiple sites and centers, that with intensive treatment, risk is significantly reduced. This was therefore a very clear and also then translated into guidelines. So this is one of the trials cited here in the recommendations of the American guidelines to aim for a lower blood pressure treatment target. So this is just one example. Maybe the SPRINT trial is unique in the sense that there hasn't been really large blood pressure trials recently. But there are some ongoing. But in terms of arterial stiffness, we probably need some more aligned with this to really get the attention that's needed. So as a last part, I thought I would look at a little bit around in the literature on some trials that caught my eye. There may be many others that I haven't listed here, but one of the things that really stuck to my memory was the 2013 paper by James Sharman and colleagues for the BP Guide study. So central systolic blood pressure, of course, is not an assessment of arterial stiffness, but I think very strongly correlated. And so I think that was in the right direction. They were trying to show that when you use central pressure to guide best practice care, that it would add benefit. And unfortunately, that trial did not really demonstrate that. It wasn't harmful, but patients actually used less blood pressure medications when guided on central aortic blood pressure. So that the only beneficial outcome was lower amount of drugs being taken, but they still achieved control. They had no adverse events, and they had no better improvement, for example, on left ventricular mass or stiffness or quality of life. So there was nothing really substantial from this that would say, yes, we need to change clinical practice and focus rather on central blood pressure, which was actually a very good question at the time based on the data. So that was actually not ideal. It would have been great if we had stronger results here to build on to go forward. There are many others. For example, here is an interesting meta-analysis of trials on mineralocorticoid receptor blockade, so that is for spironolactone, and on arterial stiffness and endothelial function. So with the drug treatment for aldosterone blockade actually improve arterial stiffness, and these 11 trials with 570 patients actually did find this. And they said current meta-analysis demonstrate beneficial effects on pulse velocity augmentation index and flow-mediated dilation. So again, if a traditional blood pressure medication reduces arterial stiffness, then I think, you know, the devil's advocates would say, well, then just treat the blood pressure, which is likely to be high anyway, and then incidentally will also have a benefit in terms of arterial stiffness. And it would have been great if we had specific drugs that would improve arterial stiffness, but it's so interweaved with blood pressure that it's often not the case. To the contrary of this trial, there was another one that looked at also at spironolactone and dietary nitrates, and they actually found that in diabetes patients, spironolactone did not reduce arterial stiffness. This one was a meta-analysis, and this was just a single trial, but nevertheless, so that there was the contrary found. And they also looked at nitrate, lowering central systolic pressure. This one was an important one on exercise and arterial stiffness in the elderly, a randomized trial from Switzerland. And they found in this study that they looked at really at people who are healthy active, healthy sedentary, and sedentary at risk. Really looked at arterial stiffness there and considered long-term physical activity in terms of arterial stiffness. And they found here that people who are at risk, sedentary but at risk, had higher pulsar velocity than healthy sedentary, and that long-term physical activity was associated with lower pulsar velocity. And they also looked at arterial stiffness after this high intensity interval training, and it seemed to depend on decrease in blood pressure. So they did look at blood pressure dependence, and it was dependent on blood pressure. So in all of these trials, this dependence on blood pressure, as I mentioned before, is pretty critical. And on the other hand, again, the devil's advocates may say, we are very well aware of the fact that exercise reduces blood pressure. So it is already in the guidelines. And if it also incidentally reduces arterial stiffness, then it's great. No need to actually add arterial stiffness to guidelines. Here we look at vitamin K supplementation. This was in chronic kidney disease, and interestingly, did not improve vascular stiffness or other measures of vascular health in this trial. So again, quite interesting, a placebo-controlled trial. Another one was looking at low-dose statin, fluvastatin, and valsartan in type 1 diabetes patients. And they did find, after 30 days, a reduction in pulse wave velocity. Percentage of change in the treatment group was significantly greater than the control group. So great, again, drugs that's already known to improve blood pressure and lipids. They will be used anyway in patients with diabetes. Of course, I'm not saying this is not important work. Of course, it's critically important to understand also the mechanisms, but I'm trying to think of how to structure them trials to demonstrate vascular aging independent as a very important independent risk factor. Other meta-analysis was on fish oil, and they have found that fish oil supplementation had a beneficial effect on pulse wave velocity. There's another one on soy isoflavones, again, adding this together in a meta-analysis, and they did find that longer supplementation of soy isoflavones reduced arterial stiffness, but need longer trials. So that is quite important because we do understand much more about the mechanisms, and it may potentially identify better treatment targets as well. So it's not all one-track minded in terms of just getting it in the guidelines. I think as more and more evidence are being generated, the much better understanding will be achieved in order to get there in the long run. So to answer the question, will the routine measurement of vascular age be implemented into clinical practice? I would say in the second point, possibly. But firstly, acknowledge that without doubt, large artery stiffness is a powerful predictor of cardiovascular outcomes beyond blood pressure. There's clear evidence for that. And as a biomarker and or as part of risk prediction, it's rather valuable. Will it be included in routine practice? Possibly yes. But as I said, it will depend on the evidence of large-scale evidence such as randomized controlled trials is required to particularly show that vascular aging has meaningful impact on clinical outcomes, perhaps in a medium risk or in a high-risk population specifically, maybe not in the general population. Maybe it's not helpful to do that already in children. It's not cost-effective potentially. It's also not, by the way, cost-effective to do blood pressure screening in children. So quite unlikely that would be the case for arterial stiffness, but again, I could be wrong. And then further value could be added if shown it is cost effective and add additional incremental value beyond standard blood pressure, which is cheap. That is a challenge to deal with. Blood pressure is cheap, easy, routinely done, and widely implemented already. And this was so far not demonstrated for central pressure in the trial that I referred to earlier, the BP guide trial. So another point, as I mentioned at the end, is therapy to improve stiffness. So there is evidence of a wide variety of interventions, mostly small-scale studies. Several of those include basically repurposing of drugs that's already developed for hypertension or for lipid lowering. Therefore, the question could be asked whether it would add additional value if we know that aldosterone, for example, reduces arterial stiffness. So that would just be my question from this side. And I think I end there, and thank you for your attention. I hope this is helpful, and looking forward to some discussion on this. Right, so I'm not sure if there are any specific questions, but very happy to take any.
Okay, thank you, Alta. Sorry about that. I was having some technical difficulty. Thank you for this great presentation for the webinar. It's really insightful and really gives us an understanding of what really needs to happen in terms of getting the vascular aging research from the research clinic or the lab into clinical practice. So if people have any questions, please post them in either the Q&A box or the chat box down the bottom of your screen, and I can pass them on to Alta for you. We did have a couple of questions that were emailed in, so I might just ask you some of those ones, Alta. So is there, in your opinion, a single measure or a mixture of measures to determine vascular age? So you talked a lot about arterial stiffness or pulse wave velocity. Do you think that we should be focusing on this biomarker or perhaps a combination of biomarkers?
Yeah, I think that's a very relevant question, which is also why I try to scan the literature on what's some of the latest developments there. I think we are early enough in terms of trying to bring it to clinical practice to say maybe carotid femoral pulse wave velocity is not necessarily the best single measurement. But based on the expert consensus documents and so on, I would think pragmatically that seems to be the logical way to go. But ideally, a single one, I think, would be ideal, that it could be widely implemented. And then, as I said, if you have a sort of a hospital with more advanced setting, then you can implement maybe more sensitive measurements add on.
Great. And another question was, how do we address the high variability in physiology versus measured vascular age? So potentially we may be 20 years old in the morning or 80 years old in the evening. So how do we really interpret the difference across the course of the day?
I wasn't really aware of the fact that it changes so much during the day. I would think it would be more stable. It's not, in my understanding, as variable as blood pressure would typically be. Unless it's operator dependent, or there are, I know that it's also you have to rest before doing a stiffness measurement, but I would think it would be a more stable measurement, whether you take it in the morning or in the afternoon. Am I wrong in that? Or are there evidence that it is it changes or is quite variable during the course of 24 hours, for example?
No, I would agree with you. I think maybe it's to do with the influence of blood pressure fluctuating at different times of the day.
That would make sense to me.
Yeah. Okay. We've had a question that's been sent in. So do you know any studies where there was a daily or weekly follow-up of arterial stiffness of the participants in a longer period?
I am very sure that there should be. There's been, if you think we're in 2021, arterial stiffness expert consensus documents were published in 2012 already. There should be several studies actually that assess pulse wave velocity over many years. I can't really think of it from the tip of my tongue. We've done a study in South Africa where we've done it for 4 or 5 years and some of it for longer. So I'm sure there would be many in Europe. If you think of those studies that were used to establish the pulse wave velocity cutoffs, there were literally thousands included in order to have the normal values. Those papers included large cohort studies, and I'm very sure they have been followed. Like the data from Jan Stassen, for example, those Flemish cohorts, Idaho and Idaho, I think they would typically have arterial stiffness over many years.
Okay, we've had another question or comment. James Sharman paper BP guide showed no change in pulse wave velocity in control or intervention group. I think it's comment.
Yeah. That is. I think that was also the finding on pulse wave velocity. So that was the trial was designed to see whether if you use central pressure to make your decisions in clinical practice on whether to change medication. Or whether to up-titrate or not, whether it would change the outcomes. And it is quite interesting that even though some of them reduced blood pressure medication, there was no difference in pulse wave velocity at the end. So how useful that is in the bigger picture, that is the question for me.
Yeah, and potentially we need some larger scale international trials to elucidate what's actually going on here. Yeah. So I had one question. I've seen another one's been posted, but I was interested in your comments about assessing vascular age in children in particular. So you, in your opinion, you don't think it's potentially beneficial or cost effective. What about high risk children? So obese children, for example.
No, I think we need to get the data to establish that. I think indeed in high risk children, that may be, I've actually written a paper about that now that I think we're commenting where I suggested that arterial stiffness assessment in children may actually be more beneficial than blood pressure because it's not that variable and it may better capture risk over a longer period of time. So I personally think that arterial stiffness has huge value. Mm-hmm. It's just how we package it, how we get the evidence to really support that. So indeed, in high-risk children, for example, this high rate of obesity that we see in children these days, I think that would be great to establish a cohort, for example, of such children and follow them over time, because we know blood pressure tracks clearly from young pre-adolescence throughout to young adulthood and later. Why would it not be the case? The mechanism may indeed be through increased early vascular aging.
Yeah, okay. Okay, great. So another question, do you know any digital health remote patient monitor systems with which patients can assess their vascular age from their homes, operator independently?
I'm not aware of any, but as I said, I'm not so up to date with the latest technology, and I know there's constantly several new devices being developed. But I know there are many new home blood pressure monitoring systems, and but not in terms of arterial stiffness. No.
The only one that comes to mind for me is the Whiting scales.
The scale.
Yeah, potentially that would be one. Yeah,
that's an interesting one. Yeah, indeed. Yes, that might be.
Okay, so another question that was emailed in, I'm going to read it because it's quite a long question. So if we create the concept of early vascular aging, where vascular age appears higher than chronological age, then what about the inverse of delayed vascular aging, where the measured vascular age is significantly below the individual's chronological age? Should we be taking steps to stiffen the arteries if this is the case?
I don't think so. Yeah. I think that would be very unlikely. It's almost, again, if I reflect to that in terms of blood pressure, it's a problem when you have very low blood pressure, but it's not a life-threatening condition. You may fall down, and if you have treatment, you may look at changing treatment when you have very low blood pressure. But the same, I think, with arterial, having great elastic arteries, you'll just go back in terms of having the same as you've had when you were a kid. And that will reduce your risk. So I definitely don't think that would ever be the case.
Yeah, okay. So if we have any more questions, please post them away. I might just ask sort of, I guess, a final sort of summary, in your opinion, for us at VascAgeNet. What would you advise that we sort of be focusing on? Because we're really trying to, translate this research now into clinical practice. And you've given us a whole number of points to go away and think about working on. But what, in your opinion, where should we be focusing our attention?
I think the challenge is to get long-term data. I use the SPRINT trial as an example there because it's such robust evidence. We have, for many years, people followed up a large sample in multiple trials. You have hard outcomes. You can say that a blood pressure that's reduced, less systolic blood pressure, less than 120, resulted in less cardiovascular events. If you can say the same for pulse wave velocity, or that a specific treatment reduces pulse wave velocity and that would result in less cardiovascular outcomes, less heart attacks, less strokes, that would be, I think, the ideal. That's the sort of evidence you need for guidelines. Just to say that it reduces your overall cardiovascular risk if you, for example, intervene in terms of pulse wave velocity, may not be enough. You need that hard evidence, and that is expensive. very expensive. So you need major funding and a major group of global collaborators at several sites, ideally, to do that. It's certainly not impossible, but that's what I think. I'm not necessarily the expert. It would be really good to have several of your previous speakers also say what they think it should be done, because there are people with more experience in this than I have. But that's what I would think when you look at guidelines and what sort of evidence they look at when they change practice. And that's why it's so important to see that level 1A evidence, what would result in changing practice. It would also be good. The study, like the study of James Sharman, I use that as a good example, because that's one of the ones where they did a randomized trial and try to see how this additional measurement or replacing a previous one of traditional blood pressure measurement would change your practice and actually result in changes in blood pressure in that case, or in stiffness over time. Similar to that, I think that's in the right line and direction, but it should be broadened.
It's really useful to have your expertise in terms of your experience on the guideline committees. So yeah, we really do appreciate you giving us your opinions. So we do have one more question that has been sent in. It says, what do you think about circulating cellular biomarkers such as endothelial microparticulars or mature or endothelial progenitor cells in vascular aging?
I think that's great. I mean, there's lots of them where you can clearly have studies in animals and more so in humans these days, for where several of these biomarkers are very helpful. But it's the same in terms of other biomarkers. I think it would, of course, be easy if it's something, I mean, I always try and think global. So you have markers like where you do with a finger prick, LDL cholesterol, you can do it in the field. You know, if we have the ability in the long term to get there with a great biomarker to test for arterial stiffness there, you don't need anything else but a rapid test, that would be fantastic. But that's a long way to go. And then you have to rank. And I know there's been many studies before saying, should we use markers of endothelial activation, for example, or a specific inflammatory marker perhaps, or whatever. So I think there's value in it. It will be to establish and identify specific ones. And these days they do this multiplex analysis where you get hordes of them, and then it becomes expensive. So technology may change over time. I mean, it's 10 years later, things may look again different. Yeah. So I think personally, I've worked a lot with biomarkers. I find them fascinating and very valuable. It's just to take it that next step. You know, CRP, for example, has been on the page discussion points for many years before it really got into acceptance. And that's a very basic one. So clinical practice is very different from research. You have to think of the GP sitting in a rural area. What are they going to do there?
Yeah, and I guess just one final follow-up question. As you touched on the GPs and the primary healthcare providers, do you think realistically that if we get to that point where we've got a device or something that can measure arterial stiffness or vascular aging clinical practice, that they're actually going to get on board to do that? I know, you know, typically their time with their patient is very limited. So do you think that it's actually going to be taken up by them, or we need this more robust evidence to sort of prove to them that it's worthy of doing?
I know there are GPs that are doing it. Few and far between. I think that just because they're interested in the measurement and perhaps opening up that conversation with the patient to tell them this is your vascular age, you need to do something about it. It's nice to have an extra tool beyond blood pressure also to discuss health with the patient. And that's why I think they've used it to show this is your chronological age and this is, you know, this is your vascular age. So this is, you need to change your lifestyle, even if that's a tool to do that. It could be helpful. So I think, you know, I think some GPs would take it up and it will take time. But the more of them that implement it, and if it's simple and cheap and quick, the better. Then I think they will speak to each other if it's really helpful. So that's the thing, we need to show and find ways that it is really helpful in clinical practice. And if so, the word will spread by itself also, I think. But yeah, time is the thing, and there's been discussions for 2 decades almost now.
Yes.
So it does take time.
Yeah. Yes, a lot of work to do. Lucky we've still got years to go, so hopefully, anyway. So
right.
thank you very much, Alta. I don't think there's any more questions that have come in. So yeah, thank you for giving this webinar. We really appreciate your time and your expertise in terms of your background with the guidelines. So yeah, thank you. And I hope that everyone online can join for the next webinar, which will be held after the European summer in September. So thank you all and have a good rest of your day. See you.
Thank you. Bye-bye.